and I'll quickly review the embryology of head and neck development, which is, I would say, like a few exam questions may be popping up for explain why kind of questions, or maybe just like a random clinical presentation with embryological concept that we have to build out here. So this particular neck develops into the future neck region from this system. We call them as pharyngeal apparatus, which consisting of these three things, which is known as the pharyngeal arch, pharyngeal pouch and pharyngeal groove. Now these three contributes to this entire head and neck region or of anatomy or whatever you have. So individually we have learned this particular arch, which is present in this region and transforms into the muscular structure, osseous structure, cartilaginous structures, and as well as this particular soft tissue ligaments which is present in our body. So this particular element that we have to keep in mind, may be given as a MCQ. Some of the MCQs may be picking up some fates of this particular arch that you have to keep here, and the clinical thing which you have to keep in mind, like a first arch is kind of like a high important for us, which is also known as mandibular process or mandibular arch, because the mandible largely develops from it. Along with that, tiny small ear ossicles, malleus, and zygomatic bone, incus, and the ligaments, these are developing from it. The muscles of the mastications, they derive of this particular element, and the muscles which is present from this region is supplied by the trigeminal nerve. So which is the rule for it. Second one, facial one, this is also the second important thing regard to this particular pharyngeal arch fate, that we have to know that the muscles of the facial expression which is supplied by the facial nerve are derived from this particular part. Along with that, the digastric bellies, posterior one, anterior one, whereas supplied by the V or trigeminal divisions. These two you have to keep in mind regard to the fates of this particular pharyngeal arch. Rest things are kind of easy, like for third one, only one muscle supplied from this particular glossopharyngeal nerve, and the part of lower part of the hyoid bone which is principally developed from it, higher part of the hyoid bone, upper part of the hyoid bone developing whereas from this particular second pharyngeal arch. And fourth and sixth contributes largely for the laryngeal cartilages supplied by the branches of vagus, superior and inferior or recurrent laryngeal, and this particular muscles which is deriving out of it is mostly coming from the muscles of the larynx. So which is this, we have to keep this particular chart in here, and out of this the defects which is coming from here, out of this particular arch defect, we call them as first arch defect, largely contribute to the defect in the mandible. So if you get any kind of like problem with the developmental error of mandible, like absence of mandible or agnathia or any kind of like ill-defined problem of the mandible, we largely direct it with the first arch error or first arch development error. We call them as first arch syndrome, etc., depending on how extensive it is. Now coming from this particular region, we are moving to this particular pouch. Also we have the 4 number of pouch. Again, this particular thing is important for the MCQs. So you have to keep this particular pouch fate as well whenever you are learning this particular fate of this particular pharyngeal pouch. 1, 2, 3, 4. Each of the pouch develops into what important structure, like 3 and 4, the important out here for us, like a third pharyngeal pouch and the fourth pharyngeal pouch, they develop into the parathyroid gland. The third is giving the inferior and the fourth is giving the superior parathyroid gland. Now why this is paradox or opposite? We know that the inferior parathyroid gland has a tendency to migrate along with the thymus, which also develops from the third one. So as a result of that, this migratory nature, this inferior thyroid artery being developed from the third pouch progresses or dips down to this particular lower end positions compared to the superior one. And other two, number 1 and number 2, this was number 1 is developing into this particular area, we call them as middle ear cavity along with the eustachian tube or auditory tube. Number 2 is developing to this particular tonsillar fossa, and again there is a difference between tonsillar fossa and tonsillar gland itself. Tonsillar fossa is the place where the tonsil is placed. So that particular space is created by this particular pouch. Coming to the other entity of this particular pharyngeal apparatus, which is known as pharyngeal cleft. This is also easy for us. This only one, which is pharyngeal cleft number 1, gives to this particular external auditory meatus or external meatus. Rest of this particular pharyngeal clefts is covered or buried by the overhanging second pharyngeal arch, which drops down and joins with this particular point. We call them as epicardial ridge and covers this particular 3, 4 and 5 cleft. Now this particular thing is covered and should normally be absorbed. If it fails to absorb, it creates the disease. This is our clinical question. Like the clinical question may be given with this particular problem, like clinical presentations, middle-aged male or female coming with the swelling just below the jaw or in front of the sternocleidomastoid at any length, at any swelling which is progressively growing up and non-painful or something like that, this is coming up. We call this particular elemental defect as an embryological defect. So if you have any kind of like a clinical presentation which shows up with progressive swelling in front of the sternocleidomastoid, gradually increasing, and this particular thing may be linked up with this embryological error, which is known as this remnant of the cervical sinus, which is known as cervical cyst. Now if these things burst open into it, we call them as fistula, external or internal, depending on how these things are bursting on. Coming to this particular entity is the tongue. So the development of the tongue develops from this particular 2 parts. One is the like anterior 2/3, posterior 1/3. Anterior 2/3 comes with the swelling, we call them as lingual swelling, right and left, lateral lingual swelling. With the midline swelling, we call them as tubercular impar, which joins in the next swelling, which is lying exactly on the posterior to it. We call them as copula, also known as hypobranchial eminence. Now point to note out here, the junctions of tubercular impar and the copula, which is this point. This point we call them as foramen cecum. This is the old house for the development of the thyroid gland. The thyroid gland develops from this particular point, we call them as foramen cecum, also known as floor of the tongue, and then the tissue goes down, develops the tongue thyroid tissue in future, which we are going to see. Apart from that, tongue, which have got like an anterior 2/3, develops from merging of these particular 3 swelling, and the posterior third of the tongue develops from the hypobranchial eminence, and farthermost or posteriormost part develops from the epiglottal swelling. So these things together transforms into the tongue. Muscles of the tongue is coming from this particular part, we call them as somoid. This particular space which is present in this particular neck region, we call them as somoid, as occipital somoid. All the muscles comes from this neck swelling or the block, we call them as occipital somoid, migrates in here. Now as it is migrating from this particular back side, it is supplied with the cranial nerve number 12. So all the muscles of the tongue supplied by the hypoglossal nerve, which is coming from the occipital somoid. This is the development of the tongue, which has got importance regard to the muscular divisions or muscular supply to it. Along with that, it has a sensory supply, it has a motor supply. Sensory means spatial sense and general sense. That means touch, pain, temperature, and as well as spatial sense, that means the taste. Taste of the tongue, anterior 2/3 and posterior 2/3. 1/3 is carried by 2 different nerves. Anterior 2/3 is coming from these particular branches of chorda tympani, which is a branch of the facial, whereas the posterior 1/3 is supplied by the glossopharyngeal. Whereas this particular general sensation is coming from the anterior 2/3 is mandibular or trigeminal divisions, and posterior 1/3 general sensation, that means touch, pain, temperature, is coming from the same glossopharyngeal. So these two are different in terms of like general sensation, taste sensation, and the muscular supply to the tongue. Otherwise, this particular tongue attracts most of the gross questions. Coming to the development of thyroid, that's what we are mentioning here. It starts the journey from this particular point, we call them as foramen cecum, which is the point of starting point. Then this particular tissue, which goes down and goes down, pushed by this particular developing tongue, the tissues which is suppressed over here, and it starts journey in front of the neck, and it goes down in front of the hyoid bone or laryngeal cartilages. Then even it goes below the larynx and finds this particular place in front of the trachea and splits into 2 lobes, into right lateral lobe and left lateral lobe. So this particular thyroid gland develops from the foramen cecum, which is an exam question. If you see the tongue question, from the tongue we usually point it to this particular foramen cecum and ask you what is the significance of the developmental thing regard to the foramen cecum. That means we are asking you to tell about this particular thyroid gland development. Then may we ask about further questions of the thyroid gland, or the anterior 2/3 of the posterior 1/3 is split into, from that particular point we call them as foramen cecum. Anterior to the foramen cecum, which is the part which is developing from the first part and supplied with the different nerves, posterior 1/3 is coming from the different part. So the foramen cecum is the important for the tongue, for the development, growth and embryological questions. Now coming to this particular thyroid gland, as it is descending down in front of the neck, settling down in the front of the trachea, it may be arrested to any point while it is migrating down. So it may be stalled at under the tongue, or maybe stalled at this particular front of the hyoid bone, maybe in front of this particular laryngeal cartilage. Then we call this particular thyroid gland in a abnormal positions. This is what we are seeing in this particular abnormal positions. Apart from that, this particular tract which is settling down to this particular foramen cecum, to this particular adult positions of the thyroid, this entire tract we call them as thyroglossal cyst. Again, this cyst should not have persisted. If it is persisted, which is abnormal, this particular cyst, if it is present, it should be present strictly on the midline, contrary to the other cyst which we call them as the cervical cyst, which is present on the sides of the neck. So if you are getting this particular cyst which is developing, which may be of two type, midline or away or lateral in positions. So depending on, you have to judge it what kind of developmental or what kind of cyst you are dealing with. And this particular swelling, if it is thyroglossal swelling, it is related to this particular tongue and this thyroid. If it is, also have that same tendency like thyroid gland. So if you stick the tongue out, protrude the tongue out, it should be pulling up this particular swelling. So any swelling on the thyroid gland moves up with this particular movement of the swallowing or sticking up with the tongue. So that's how this particular thing can be eliminated out or separated out from this particular lateral swelling of the neck. These are the normal positions where this particular thyroid gland may be found. Apart from that, if the thyroid gland deviates from these normal tracks, lands up into the place where it should not be, then we call this as aberrant thyroid tissue, which is away from the normal thing. It could be anywhere migrating there. Then we call them as these particular abnormal positions of the thyroid. So development of the thyroid, rather this particular thyroglossal duct cyst, which we are going to talk later on as well. So which is a point of interest, and the cervical cyst, that also we have to keep in mind. Regarding the development of the face, we do not ask about the story about development of the face, rather we ask about the error of the development of the face, which is related to the cleft lip cave palate problem. For that you have to understand the face development from three projections: frontonasal, maxillary, mandibular. The mandibular fuses, forms the jaw and the lower lip. This particular frontonasal splits into two parts, frontal and nasal. Nasal frontal process, which has got like a further ramifications or further changes. This particular nasal process, which is having the lateral part, which is present on here, we call them as lateral nasal prominence and medial nasal prominence, depending on the presence of the nasal pit, which is splitting this point and making a groove, which is going to be the future nasal cavity. Now this medial nasal prominence meets in the midline, right side and the left side. So this meeting of the medial nasal prominence over here, meeting in this particular point, is falling on these together and getting down, falls the philtrum of the upper lip, and the rest part of the upper lip, which is known as vermilion border, formed by this maxillary process. So this particular lip formations is contributed by these two things, which is known as medial nasal prominence merging, forming an intermediate part, we call them as the intermaxillary process, which forms the philtrum part or central part of the upper lip, whereas the vermilion part of the lip formed by the meeting of the maxillary process. See, this is orange thing, and below one is the mandibular arch or mandibular process, which is joining in here, forming the jaw and as well as the lower lip. So this is how this particular lip is formed. So if this particular union, if something goes wrong, we may have a split. We call this as cleft lip. We are going to see. So somehow this particular medial nasal prominence, if it fails to fuse, or if this particular intermaxillary process fails to fuse with this maxillary process right side and left side, we get this particular error also known as the cleft lip error, median or lateral cleft lip, which you are getting in if this particular meeting of these particular tissues are in trouble. So this particular element that we have to keep in mind regard to this particular development of this particular cleft lip and cleft palate. So this cleft lip may be in the midline, strictly midline cleft lip, or known as median cleft lip, or maybe lateral cleft lip, which is more common, which is maybe associated with the split palate. So this particular midline cleft is known as median cleft lip, which may be just like incomplete fusion of medial nasal prominence. It may be having this particular fusion error with the lateral cleft lip, where this particular medial nasal prominence is properly formed, but the interactions with the maxillary prominence may be there, may not be there. So maxillary prominence may not be meeting with this particular medial nasal prominence, giving to this lateral cleft lip. This may be present with this particular cleft palate. For that, we have to know this particular palate development. There are two parts of the palate, we call them as primary and the secondary. Primary palate develops from the intermaxillary segment, which is present in the midline. So which is in front of the foramen cecum, which is the tiny part, along with the four incisor teeth are developed from here. The rest part of the palate, or this particular the palate, develops as a secondary palate, which is the black one as we are seeing. The secondary palate develops from this particular same maxillary prominence that we are seeing. Right side, left side gives this particular prominence, which is known as palatine shelves. So right side maxillary prominence, left side maxillary prominence keeps a kind of shelf, we call them as palatine shelves, meets in the midline. If they fail to meet in the midline, then we get this palate which is split. We call them as split palate, also known as cleft palate. Maybe associated with the cleft lip, then we call them as cleft lip, cleft palate error, or maybe isolated cleft palate error may be there. So this particular lateral cleft lip may be because of this particular fusion error of the maxillary prominence. So cleft palate, secondary cleft palate, which is most common, along with the cleft uvula, that means throughout this particular soft palate and hard palate it splits. Lack of fusion of this particular palatine shelves, where from palatine shelves are coming, this is projection coming from the maxillary prominence. What is the maxillary prominence? These orange people which you are seeing here, right side, left side, they are not meeting in the midline, keeping a gap in here, leading to this particular error. We call them as cleft palate problem. Development of the nose, we have this particular nose, have got these particular parts, we call them the tip of the nose, root of the nose, and the septum and ala. You see that ala part which is coming over here have a purple shade, that means it is developing from the lateral nasal prominence. This one which is coming over here in midline, which is fusions of the medial nasal prominence. And then we have this particular nasal cavity develops from this particular nasal pit, which is projecting on the back and creating the cavity. So this is how this nose is formed. Once this nose is formed, then we have this particular nose develops in the paranasal sinuses. So this nasal cavity projects on the lateral bones which is present on this particular sides of it and creates this particular paranasal sinuses along with this particular surrounding bone that it has. Mostly like maxillary prominence, maxilla we have, then we have this maxillary air sinus. If it is going backwards, it creates the ethmoidal sinus. We have the frontal bone likewise, etc., etc. So the only sinus that we are born with, the greatest or the largest one we have, this maxillary sinus. So when we are born, we had only one sinus. Later on, as the nasal cavity develops, we develop further sinuses within this particular neighbor or surrounding bones. So this is about this particular developmental revisions of the palate, which is required for the face, and along with this particular neck region developmental problem. Cleft lip, cleft palate, which is frequently reported to us, being visible to us, and this particular thing which is quite common in male and female equally have an incidence, but more incidence in the male we see with the cleft lip problem than that of this female problem. And in the neck, you have to prepare this particular two entity, thyroid gland and thyroglossal duct cyst. So this particular thyroglossal duct cyst, which is the tract through the thyroid gland migrates from the foramen cecum to the adult position, this tract should normally be absent. If it fails to regress, create a cyst, we call them as thyroglossal duct cyst. The cyst being in the midline and linked up with this particular tongue and the thyroid moves up with the swelling and moves up with the sticking of the tongue. Compared to the swelling, which is another with the developmental problem that we have, maybe with this particular side of the neck. We have this swelling or gradually increasing, we call them as cervical cyst, which is nothing but the cervical sinus fails to regress. If it fails to regress, it remains on the side of the neck. Having thyroid swelling, it should be in the midline, in front of the neck region. So, this particular thyroglossal duct cyst and the cervical cyst can be separated out by its position and how it is examined with the movement of the tongue or movement of the swallowing. So, this element and this particular charts that we have to keep in mind for MCQs and for theoretical question explanation, explain why. Cleft lip, cleft palate, development of the tongue, development of thyroid, development of the cervical sinuses and fates of this particular arch, which is this particular chart.